There's so much to say about pelvic health, but I'm going to stick with the age-related changes and just what is the pelvic floor in general. But I mean, I could do a workshop on 1,000 different things. We could talk about pelvic pain or just incontinence in general. There's just so many different things. So my name is Desiree. I am the owner and physical therapist of Integrated Pelvis. Integrated Pelvis is a mobile practice on treating the pelvic floor. My main focus, not my only focus, but my main focus is going to be anywhere from here to here. What the pelvic floor is, essentially, is a group of muscles, okay? It's in an intimate area, so people tend to get nervous, but at the end of the day, it's a group of muscles, fascia, ligaments, but the pelvic floor is a group of muscles. So it sits at the bottom of your pelvis like a bowl of musculature, indicated by the red. There's multiple layers, so that's why there's so much there. There's 4 main functions to the pelvic floor. The pelvic floor is going to provide sphincteric control. So it all starts with S's, if you guys forget. Sphincteric control that has direct attachments to the urethra, the sphincters, as well as the rectal sphincters to help to maintain continence. They help you not to pee and poop yourself if they're doing their job, right? If they're doing their job. That's the first main function. The pelvic floor is technically only 3 muscles. There's a lot of muscles down there, so we kind of just call it the pelvic floor. But there's a lot of muscles down there that we say, because they have such a close relation with the pelvic floor, they're so connected that we just say it's all the pelvic floor. So the next S is going to be support. If I had my full model here, you would see the uterus sitting in the pelvic floor, the bladder, and the rectum. So those are your pelvic organs. And that is why a lot of times with the pelvic floor, any dysfunction with one of those 3 things, so like bowels, urinary habits, and sexual function, is likely related to what's going on with the pelvic floor itself, because they have direct attachments. It's all very connected in that area. So support of those organs, sphincteric control, stability is your next main function of the pelvic floor. So it provides stability to the pelvis, right? Any muscle around a joint or bone is going to provide stability, as well as the low back area, because this is your pelvis is here, and then your back, you have your lumbar, thoracic spine, which is the middle back, and then your neck. Okay? So stability is your next S. And the last S is sexual function. I'm going to pass this around if you want to take a look. The next S is going to be sexual function. Because of that close relation with the uterus, obviously surrounds the vagina. You need the pelvic floor to be functioning well to have an orgasm. You need the pelvic floor to be functioning well and not super tight, to not have painful intercourse, or it's also called dyspareunia. If you ever hear that word, it's just painful intimacy. Also, it helps to provide lubrication to that area. Those are kind of our 4 main S's as for function of the pelvic floor. Next, we'll get into primary dysfunctions of pelvic floor. Most often, what I'm seeing if somebody has pelvic floor dysfunction is going to be urinary incontinence because of that sphincteric control, so leakage. And that could be not just when you cough, sneeze, laugh, but most often you hear people go like, crossing their legs before they sneeze because they might leak. But it could also be just when you are on your way to the restroom, right? It could be when you're pulling your pants up, or even when you just finished going to the restroom. You get up and walk away and then you might leak, right? All of those are urinary incontinence. All of those are leakage and incontinence, because the amount of times that I have a woman that comes and sees me and I go, do you leak? Are you leaking? And they say no. And then we keep talking about it. I'm like, well, first of all, that's probably why you're here majority of the time.
Right, liar.
And yeah, it's always like, well, when I go to the bathroom, I'm peeing myself. I'm like, that is leaking. That's literally urinary incontinence. A lot of people think it's when they lift something or just when they cough or whatever. Oh yeah, I might leak. But there's so many different types of urinary incontinence. That's definitely the primary reason why I see people. That could also be
people don't say it because they're like embarrassed,
Yeah.
or they've done something.
Oh, I get it
wrong
out
to
of them
make
quick.
it that. You know what I mean?
Absolutely.
It's something that they could have prevented.
Right. Definitely the embarrassment is the main. So just a fun fact, at least 50% of women experience urinary incontinence, but we know that it's so much more. The number is so much higher than that because people don't report it. Right. They don't talk about it. Same with painful intercourse and stuff like that too. But anyways, so as well as urinary incontinence, but also fecal incontinence. So you might be leaking a little bit of stool on the way to the bathroom, or when you cough, sneeze, that's all pelvic floor related. Urinary urgency, I have to go to the restroom every 20 minutes, every 30 minutes, every hour, right? Those are all abnormal amounts of times I have to go to the restroom. Urinary frequency, same thing. Basically anything going on here, pelvic pain can radiate to the lower back. So they might go, do I have herniated disc? Like, what's going on with my lower back? And it could literally be your pelvic floor tensing up and having a lot of tightness. it depends on what's going on with your pelvic floor. I would have to examine. I always tell people, because they'll go, well, what do I do for this? And it's like, you could have the same symptoms as Mariah, and your pelvic floor could literally be doing opposite things.
And how
And
do you
so,
determine what it is? By doing an internal exam?
yep, we don't push an internal exam if people don't want to do it, but it's the best way.
Okay.
By far, it's the best way to find out what the heck is going on. Because at the end of the day, like I said, it's a group of muscles. If you were to come to my practice and say my shoulder hurts and I never touched your shoulder, right? It doesn't make any sense.
Right.
You have to assess it. So usually I can, discuss those things with people and they're pretty open to doing it. But sometimes people don't want to, and I just have to shoot from the hip and say, okay, well, we'll try this and see and take turns if we need to.
So when you do the internal exam, are you pressing on the side? Are you feeling for muscle tone? Like
Yeah,
what kind
I feel for muscle tone. I feel for strength. I check the coordination of the pelvic floor. If there's any pain, I kind of dig a little bit deeper into that in the sense of like trying to figure out where that's coming from. But I also do an external exam too. So like what's going on in the vulvar region. And that's typically what I start with. Sensation testing, reflex testing, all that is part of your body. So you do kind of the same thing that you would do for any other body part.
If you're mobile, where do you do that?
At their house. So I usually tell people before I see them, like, hey, is there a private area? Or we can do it in your living room if nobody's home. I bring my treatment table and all the things that we need with me. I also see pregnancy and postpartum. Highly recommend if you know somebody's pregnant, you should be telling them to go see a pelvic floor physical therapist. There's so much that happens when you're pregnant. A lot of weight on the pelvic floor that can increase symptoms. Pelvic girdle pain is huge. Majority of my pregnant patients that come and see me have pelvic girdle pain. So that's like pubic symphysis dysfunction, SI joint pain and dysfunction, shooting pain like sciatica type symptom that can all be due to pregnancy because of the shift in your pelvis, right? Your belly grows and you kind of adjust your center of gravity and get into that more anterior pelvic tilt, which can affect your balance, everything, right? Your whole body changes. I always tell people pregnancy is an orthopedic event. Your whole entire body is changing, not just your pelvic floor. You can have neck pain. We kind of went there a little bit earlier too. Postpartum is another huge population that I see for obvious reason. You have a baby that's sitting on your pelvic floor for 9-10 months. So that can cause a lot of damage, weakness to those pelvic floor muscles, whether it's just weakness in general, or they might even be experiencing pelvic pain due to various reasons, but oftentimes maybe like a traumatic birth, C-section, the scar, the immobility of that tissue can cause pelvic pain, or just weakness in general. It's all very connected.
Yeah.
I don't do internal exam on pregnant. It may be later in the third, like say like if they're having a lot of pelvic pain or something.
Okay.
Yeah, we usually wait until after. And I could go on and on, but we'll switch gears a little bit just because time. Getting into age-related changes. As Jen talked about earlier, as we age and go through perimenopause and menopause, our estrogen drops significantly. So this directly affects the pelvic floor because in the pelvic floor is loaded up with estrogen receptors, right? So when you get that drop in estrogen, those estrogen receptors are now malnourished. And estrogen is going to help to bring blood flow to the area, brings great vascularity, lubrication. It can help with a variety of things. The pelvic floor elasticity. When you get that drop in estrogen, that's when you usually will find that you get that vaginal dryness, pain with intimacy. Not always, but oftentimes that's what I see with my GSM patients. So that's genital urinary syndrome of menopause, itchiness, burning, frequent UTIs, urinary leakage. There's quite a list there, but those are the main ones. My recommendation, not just with pelvic floor physical therapy, but also to put them on a vaginal estrogen versus oral or a cream. I most often, actually always recommend a vaginal estrogen. In combination with pelvic floor therapy, we could find a good vaginal moisturizer for them. We could definitely get them on a good lubricant if they are sexually active, which oftentimes people are. It's a stigma that older people don't have intercourse. They absolutely do.
They have more than younger people.
Yep, they got more time on their hands. That is the major change that you'll find with aging with the pelvic floor. Any questions about that?
What are you looking at as far as age ranges for perimenopause and menopause?
So you may know different numbers. What I've seen is usually anywhere between 45 and 55. Does that concur with what you?
No, most women at perimenopause starts around 30.
That early?
Mm-hmm.
Oh,
Yeah.
wow.
Yeah, your progesterone actually starts dropping in your 30s. It depends on what you're exposed to.
I was 22.
Well, some people have different like
Yeah.
PCOS and endometrial, fibrosis, different stuff like that.
Okay.
Their numbers can be way different. A normal woman with no other diagnosis is normally like 30s, sometimes 40. It just depends on how many disruptors you are exposed to in your life. It's really how you grew up, like how your parents were, like what you were exposed to in the uterus, and all these things. That really plays a huge role.
Also, if you've had a hysterectomy, you're definitely in
Hysterectomy.
menopause.
Women are like, oh, I don't have a period. Yeah, that's not good. I know you're happy, but
When you're 16 years old and you're complaining that your period's hurt, they can just put you on birth control.
yeah, they just put you on birth
Okay.
control. Birth control is actually really bad for you. So it really affects how your hormones will be when you get older.
Since you were talking about it, I do want to talk about this as well. The pelvic floor, think of it, it's part of the core. So think of it as part of like a canister system, right? So the core is essentially 4 groups of muscles. You have the pelvic floor, the diaphragm, which is a breathing muscle, which is why you started to feel it when you were doing the deep breathing. The multifidi, which are in your lower back to help stabilize your spine, and then your deep transverse abdominis muscles, the deepest abdominal muscle. Those are your 4 core muscles. They all work together and function together without you even thinking about it, okay? But what I kind of do will help to bring mindfulness to that area so that people can connect to it. Because sometimes it's not a tightness in their pelvic floor. It's not an underactivity. It's not super weak. It's just their whole system's uncoordinated. It's not doing what it's naturally supposed to do and moving together. That can be for a variety of reasons. You guys can all practice this if you want to put your feet flat on the ground, get knees apart. So what you're going to do is I want you to take a deep inhale through the nose, let your belly expand, and I want you to kind of feel for where your pelvic floor is. And I want you to exhale through the mouth, let your belly come up and in. That's naturally what it should do. Let's do a few of those. Almost all of my patients say that. That's not typical, right? Your natural coordination of it should be as you inhale, diaphragm expands, and your belly should rise. Well, the pelvic floor is 70% involuntary. That's why you don't have to think about expanding your pelvic floor when you pee, right? Or maintain continence. 30% voluntary. So you can control them. If people have that incoordination where it's like, oh no, I'm doing the opposite, then I bring that voluntary control in there to help them get more coordinated. Maybe you just had a baby and your pelvic floor is angry and mad at you because of all the trauma to that area, right? Or you have a history of mental health, psychiatric issues, and then that's all kind of catching up. You hold a lot of tension in your pelvis. So it could have been just stress in general that made your pelvic floor clench up. Could be you're sitting more often than usual and your body's in certain positions that it doesn't like to be in. Usually I do like mobility, like stretching. I do manual therapy on my patients with all my patients with pelvic pain. Research shows that's the number one best way to treat it. So it's usually like internal manual therapy to those muscles because again they are muscles, right? They need to be treated like muscles.
So what does that look like a massage, like massaging the muscle?
So yeah, so it could just be like long holds, like I'm pushing and it doesn't feel good. But then we can usually get them to release, right? It's like if you get deep tissue massage, you get those muscles to release. Could be something called Theo's massage, or we're just pushing and getting that muscle to relax. Does anyone have any other questions?
Can you tell us how we do a Kegel?
Yeah, you want to practice it?
Yeah.
Yeah. If you do have pelvic pain right now, I wouldn't recommend doing this, by the way. You don't have to tell anybody because nobody knows if you're doing a Kegel or not. Oh, you can sit with your feet uncrossed, feet flat on the ground. So what I want you to do, again, because of the coordination with the core, right? So we're going to include the breath work with it as well. Kind of feel for where your pelvic floor is. You know where it's at now anatomically. Try to feel for that sensation here. What you're going to do is as you exhale, you're going to squeeze the pelvic floor muscles up and in, exhale through the mouth, as if you're trying to stop the flow of urine. So you guys can go ahead and do that on your own. If you're having difficulty doing that, you're more than welcome to add in a little bit of a hum. So yes, you heard me right, because the pelvic floor has connections from here all the way down to your feet. And that's we could go on and on. But because of the vagus nerve, it travels all the way down to the pelvic floor. So you can even try that. Even if you do feel it, try a little hum and see what your pelvic floor does. What does it do for the people doing it? It lifts up and in. Mm-hmm. Lots of connections.
It's kind of like when you squeeze, like you're gonna pass gas. Like
Yeah,
squeeze
so
and, like tighten it.
people kind of understand it with different cues. A lot of times I'll say stop the flow of urine. Another one that I say, it sounds silly, but it literally helps, is as if like there's a blueberry at your vaginal opening and you're trying to suck it up. Suck it in. Because a lot of people they think that they're doing a Kegel and they are squeezing their glutes. They're squeezing their hip adductors. They're not really squeezing the pelvic floor. They're using compensatory muscles to do it. And that's something I can help people with, but I don't want you to get into the stigma of like, oh, we just do Kegel training, because there's so much more to pelvic floor physical therapy than that. Oftentimes, when you have leakage, it's not just when you're sitting here, right? It's when you're doing functional things. It's far more functional than that.
So how well does the therapy work? I have a lot of elderly women who take oxybutylene and different medications
Yeah.
for urinary incontinence.
Mhm.
How far is too far for therapy?
I get far more results with those patients, but there's research that shows, there's plenty of research that shows that pelvic floor muscle training is going to be far more beneficial. They still come and see me. They have the surgeries and they get the mesh and they get the bladder lifts and all, and they're still coming to see me.
Are women scared? Even the people who already had a PES, they were still sending them out because they would still
Absolutely.
feel pain and everything.
Yeah, it should all be used in combination. I'm not against pessaries. I tell my patients with prolapse, that's another big one that I forgot to mention earlier.
How do we prevent that? Weightlifting?
Definitely pelvic floor physical therapy, learning how to train those muscles, as well as definitely keeping everything here strong. The pelvic organ prolapse, there's a few different types. You can have a bladder prolapse, you can have a uterine prolapse, rectal prolapse, you can even have small intestine. So essentially is when it could either be a significant weakness of the pelvic floor most often, or there's also ligaments that hold up those organs, right? But maybe you're postpartum and those ligaments, because of hormonal changes, are a little bit lax. But it's essentially them pushing down in the vaginal opening. So you can either have a prolapse that's maintained in the vaginal opening or coming even through the vaginal. It's so much more common than you think. At least 70% of my patients have prolapse, and that's being generous. Pregnancy, postpartum, because of all that weight on your pelvic floor. Breastfeeding too is another big one because of the hormonal changes. And then as you age, just weakness in general. And you might not even know that you have a prolapse too until it starts to bulge, or they get symptoms like urinary incontinence, stuff like that. Because again, that's just a weakness of the pelvic floor, right? Those organs sit here. And then if gravity kind of takes over and pelvic floor is weak, then they can.
Is the mesh what picks it back up?
Yes, but again,
Mesh is very
so many people have had surgical treatment for this and it didn't help. Or it did help for a little while. Any other questions?
People without a uterus have a higher instance of having bladder prolapse too.
Because of that drop in estrogen.
If you could keep your uterus, keep your uterus.
But you can also have a uterine prolapse. All right. It was a pleasure. Thank you guys for listening.